Chair of the Commission. Good morning, everybody, and welcome to our meeting this morning. It seems like our agenda is not too long today, so we can get started. Joseph, could you please proceed with the roll call?
Yes, thank you, Dr. Khan. Joseph Filippi, Executive Director for the record. Commissioners, I'm going to start with our voting members today. When you hear your name, if you could please just let us know that you're present. Starting with Commissioner Jalen Behunin.
Present.
Thank you. Commissioner Walter Davis.
Present.
Thank you. Commissioner Flo Khan. All right. Commissioner Marilyn Kirkpatrick.
Here.
Commissioner Bethany Sexton. Commissioner Wendy Simmons.
Present.
And Chairman Khan.
Present.
Perfect. So we did have a notice ahead of today's meeting. So we have Commissioner Bio-Curry-Winchell, Commissioner Andre Peterson, both gave notice that they would be absent today. So we'll mark them excused. Assuming Flo, Khan, and Bethany Sexton are planning to join, they might just be a few minutes late. So we'll go ahead and mark them present once they're able to hop on. But Chair, we do have quorum today. Just want to note really quick our non-voting members from the state agencies that we have today. Insurance Commissioner Scott Kipper is out, but I believe we have representatives from the Division of Insurance on the call today. Director Richard Whitley, he did give me notice he was just going to be a couple minutes late this morning, but he will be present in a few minutes. Curious if we have Executive Officer Celestina Glover on. Okay. And then Executive Director Russell Cook from the Silver State Health Insurance Exchange said he would be absent excused as well. But Chair, we do have a majority of voting members today, so we can go ahead and proceed with today's public meeting.
Thank you, Joseph. So we can proceed with our next agenda item of public comment. This is the next item on the agenda. Please keep in mind it's 3 minutes for the presentation. Joseph, do we have any people for public comment?
Thanks, Chair Khan. Joseph Filippi for the record again. So anyone wishing to provide public comment this morning, either by phone or computer, if you're joining by phone, please dial the phone number 775-321-6111, and when prompted, provide the meeting ID 467-104-852#. And then if you're joining by computer, just use the raised hand feature in Teams. Go ahead and raise your hand if you would like to make public comment this morning. And Chair Khan, it looks like we don't have any requests for public comment.
Thank you very much. So moving right along, the next item on the agenda is for action. I believe all the commissioners have received the minutes of the previous meeting from August 16, 24. I'm presuming everybody has had a chance to review them. Any comments on the minutes? Any changes recommended or otherwise from anyone? Hearing or seeing none, call for a motion to approve the minutes.
Mr. Chairman, Wendy Simmons, I move we approve.
Thank you.
Walter.
And second?
Walter Davis, I second.
Thank you. Any opposed? So the motion carries. Thank you very much. The next item, number 4 on the agenda, is the overview of Nevada Area Health Education Centers, AHEC, and related policy considerations. Joseph, if you want to introduce our guests, the allotted time for this is 20 minutes.
Yes, thanks, Dr. Khan. Joseph Filippi for the record. So today, I'm really happy to have with us, we have Andrea Gregg. She serves as the Chief Executive Officer with High Sierra AHEC, or the Area Health Education Center. And then we have Mr. Gerald Ackerman, who serves as the Director of the Nevada AHEC program located within the School of Medicine at the University of Nevada, Reno. So hoping that they can the presentation today is going to give a great overview of what the Nevada AHECs are and what they do in Nevada, and then opportunities as well to address the workforce needs of the state. So I'll go ahead and hand it over to both Andrea and Mr. Ackerman.
Perfect. Thank you, Joseph, Andrea, Greg, for the record. Good morning, Chair Khan and members of the commission. First, thank you for the opportunity to speak with you today. Gerald and I are here really to provide an overview of the vital role that Nevada AHECs, Area Health Education Centers, play in really developing and helping to support the shaping of our state's healthcare workforce. We know that many of you are aware of the demand for healthcare professionals, especially in primary care and certainly in underserved and rural areas. It continues to rise, and the work that we're doing is providing some small movement to that area. So today, we're here to share with you how AHECs really are uniquely positioned to address these overall challenges by creating educational pathways that really foster career development and build a strong and diverse pipeline across the state. Gerald and I will walk you through the purpose, both nationally with Nevada, nationally and within Nevada. We'll share insights into our regional centers, and then we'll also explain how we're funded and how highlight how AHECs are already really contributing to workforce development efforts. And all that being said, before we start, we'd also like to thank the commission truly for your dedication and work in addressing these critical needs. And we're really appreciative of your ongoing commitment to this important work. So with that being said, Gerald, I'm going to go ahead and kick it over to you.
All righty. Well, thank you, Andrea. For the record, my name is Gerald Ackerman. I direct the Nevada AHEC program, and I'm Assistant Dean for Rural Programs for the University of Nevada, Reno School of Medicine. Chairman Khan and members, thank you for your commitment to our workforce and healthcare access in Nevada. The work that you do is vital. So I first would like to start kind of on a high level. So the National AHEC organization represents a network of more than 300 AHEC program offices and centers that serve over 85% of the United States counties. The the National AHEC organization mission is to help its members achieve the AHEC mission through advocacy, education, and collaboration. Area Health Education Centers are funded through the Health Resources and Services Administration, HRSA, under the AHEC program, which is authorized by the Public Health Service Act. The funding typically comes from HRSA's Bureau of Health Workforce. The AHEC program provides grants to academic institutions, which can include medical and health profession schools. These grants are used to establish and maintain AHEC centers and programs, which focus on developing a healthcare workforce that is trained to meet the needs of rural and underserved communities. The funding is awarded in 5-year cycles and supports various initiatives like health career pipeline programs, continuing education, healthcare for providers, and community-based health professions training. The AHEC program was established by Congress in 1971, and Nevada received its first AHEC federal grant in 1987. In 1989, the Nevada Revised Statute established programs specifically designed to enhance health services in underserved areas. This marked a significant step in addressing healthcare access across the state. Fast forward to 2000.
Sorry, Gerald. Sorry to interrupt you. Maybelline, or what slide are we on here?
We're on 3, I'm sorry.
Thank you. Okay, sorry. We just want to follow along with you.
Okay, I'll tell you to change slides. I apologize.
Thank you. No, I appreciate it.
Fast forward to 2003, during a special legislative session, the language was updated to reflect the evolving needs and priorities of our healthcare system, ensuring that these programs remain relevant. In 2012 and 2020, many of the programs established within the NRS, which we've included there, faced reduced state funding due to budget cuts. Unfortunately, the cuts were not restored and remained unaddressed. This led to several significant challenges, including hindered expansion of workforce development programs, especially those K through 12 students, service gaps and increased unmet needs in underserved and rural areas, and strains on existing resources, limiting AHEC's ability to meet growing demands. impact on program sustainability, threatening the long-term viability of some critical initiatives. Despite these challenges, however, Nevada AHEC for over 35 years has advanced its mission through 3 centers providing services statewide. Slide number 4. I include a copy of the Nevada Revised Statutes. This established the Area Health Education Center program within the University of Nevada School of Medicine, Reno School of Medicine, to support health care education and training. Programs and duties include assisting AHECs across Nevada in providing career opportunities, continuing education, and stipends for students and residents serving an underserved area. The statute also maintains the development of training programs for primary care and other critical services, including the availability of healthcare providers both in urban and rural areas, promoting interdisciplinary learning opportunities, and all funds that we receive, both federally and state, apply to those mission initiatives. Next, I'd like to kind of go over what our AHEC program looks like within the state, for those of you who aren't familiar with it. Next slide. We'd like to highlight the key operational structural differences among Nevada's AHEC centers. It's interesting when you talk to our national colleagues, AHECs are hosted and anywhere from hospitals to educational institutions to nonprofits, and that's the same in our state. The difference among Nevada's AHEC centers, to help you understand how these factors affect each center's capacity to address healthcare workforce needs. Frontier AHEC and Desert Meadows AHECs are both hosted by larger organizations. Frontier by the University of Nevada Reno School of Medicine and Desert Meadows by Co-Imagine Health. Being hosted by these institutions means their budget and staffing are likely integrated into larger structure of the hosting entities, which can both support their work and limit the autonomy of their operations. In contrast, High Sierra AHEC in Reno is an independent 501c3 organization, giving it more flexibility to manage its operations, seek diverse funding sources, and tailor its initiative more independently. However, the centers do work together very closely on all of our initiatives. Next slide. I would like to show you also how each center is currently funded, and it's kind of hard to put all these charts and tables together. It's a very busy slide, but a lot of these funds, especially within the School of Medicine, are not initially targeted to AHEC, but we tap into those funds to help with our one-to-one budget match that we have to do for our federal grant. So that being a busy slide, I'm going to try to break this down. We want to focus on federal and state funding disbursements while also reviewing the financial differences between each center. First, it's important to know that AHEC Center receives an equal share of federal and state funds to support healthcare workforce development and community health initiatives across Nevada. While equal funding allows for foundational support, the diverse needs of the geographic differences across the state mean that some centers face unique challenges that require additional resources. For example, Desert Meadows AHEC is currently operated on federal and state funds only. Due to their various limitations, it becomes challenging to identify and pursue additional funding via federal grants and contracts. For those AHECs supplementing funding, they are doing so through a combination of federal grants, state and county contracts, foundational support, fundraising, and self-funded activities, and program service income. Addressing the evolving healthcare demands and workforce needs presents an opportunity to expand and broaden AHEC programs. With appropriate support, there is potential to significantly expand services, reach more students and communities, and further strengthen Nevada's infrastructure. I would like to now turn my time over to Andrea, who will talk us through a few remaining slides, and then I'll come back.
Perfect. Thank you, Gerald. Next slide, please. And again, Andrea Gregg for the record. So really today, my objective in supporting this presentation is to work, through the next slides to really take you through a deeper dive into all of the amazing work that's happening throughout the state, and certainly through the strength of each AHEC center. Really at our core, and as we frame the mission of our work, what AHEC is doing at all points of programming is we're really finding ourselves navigating through the interconnected themes that are on your slide here. So really the ideals of connecting communities, advancing workforce development, cultivating inclusivity, as well as aiming to transform care. Through each of our innovative programs and services, we really are working towards building a comprehensive framework that not only addresses the immediate needs throughout the state of Nevada, but really also supports laying the foundation for a more sustainable and inclusive healthcare system longer term, where our goal is that everyone, regardless of background or circumstance, really deserves access to quality, dignified, and compassionate care. Next slide. So through that work, our mission is here on the slide, and I really just invite you to review our mission and the photos to the right of your screen, which really highlight our initiatives supporting healthcare workforce at every stage. Our center here at High Sierra and others are starting to slowly implement. We start as early as 5th grade and we go through that continuum. Preceding slides will take a deeper dive into those programs. But what we're really doing here is bridging the gap by guiding students into healthcare careers and aiming to link practicing professionals within the communities that they serve, while also improving health outcomes across the state of Nevada. Next slide. So at the core of our work here too is our overall vision. We had the great pleasure of coming together as a statewide network over the last year to really put some intentional thought into a statewide strategic plan. And through those efforts, we have revisited our organizational vision, and they're listed here. And really, the top 4 are that anything and everything that we're aiming to do is to empower the next generation of Nevada's healthcare leaders. As I mentioned, we start as early as 5th grade, and we are dedicated to the concepts of, just a more upstream approach for longer term outcomes to support the state's needs, while really investing in those individuals to grow our own. Second, through each of those programs, we are fostering growth of committed healthcare students in Nevada through advanced education, while always emphasizing mentorship and skill development. Every student that we're reaching is sharing with us, or through our eligibility thresholds and criteria for our programs, that they do want to stay here in Nevada, and they do have a genuine interest in reaching underserved populations, to include rural. Each of those efforts, we are also promoting health equity, compassion, and inclusion, really through the empowerment of those healthcare professionals with use of education and tools that really implement culturally aware practices for those aspiring healthcare professionals who will be the future practitioners for our state's population. And then lastly, we would not be where we are today if we didn't prioritize, really the power of collaboration, and through that effort, really forging strong partnerships that aim to bolster the state's healthcare workforce ecosystem and really foster collaboration and unity, where we can, really lock arms with like-minded partners to make a greater impact. Next slide. So this too is a busy slide, fun to put together, but it will give you a snapshot of all of our programs. So if, really, as you join me on a journey with one of our students progressing from K through 12 through our pathway programs, if you see the individual sitting in the desk on the left side of your screen, and then follow that person as they now have become mentors at the undergraduate level to their younger peers, then moving on to graduate and doctorate level as they continue those aspirations, and then finally reach the end of that continuum, which is becoming that practicing professional, again, who aims to stay in Nevada. So this in its illustrative form really is the work that we do. The program logos there at the bottom of the slide will showcase everything that we're doing across the state of Nevada. So as I mentioned before, and I hit on this all the time, our programs really do begin with 5th through 8th grade. At that point, we're offering hands-on education, virtual reality, really active learning experience that are intended to spark continued interest in health and STEM fields. Students are building critical thinking and problem solving, and then most importantly, they're doing teamwork skills, working directly alongside local professionals. And then within the Project Prevent and reach out and revitalize rural. It's a mouthful, but those particular schools are targeting Title I high schools as well as rural communities. And what we're doing here is developing a workforce that meets the diverse community needs while providing, again, opportunities for those students to immerse themselves and engage within their communities. At the undergraduate level, we're engaging community leaders who support AHEC's mission and really contribute to healthcare education. These student ambassadors, which we're very proud to say there's a student ambassador program at each of our AHEC centers across the state. These individuals are becoming the lead peers and helping to drive lead initiatives while networking in the community, gaining professional skills, and then really representing AHEC in all that they do. And the fun part about the ambassador program is that they go back to the K through 12 kiddos, and they then teach our curriculum throughout the state. And then as we move along, let's see, the AHEC Scholars Program. This is part of a federal initiative. What we're doing here is preparing healthcare leaders to serve rural and underserved communities. This is the final step within our pathway programs. And really what it's doing here is positioning our scholars to be a key source for talent acquisition, really ensuring that employers have access to a diverse and highly skilled workforce. That's been tailored to meet Nevada healthcare needs specifically. Our medical rotation programs and rural outreach clinics are going to offer hands-on experience, interprofessional education, and patient-based services. And these rotations also help bridge critical healthcare gaps in rural regions while equipping students with essential real-world skills. And then finally, we have our signature community health worker training program, which is equipping individuals with the skills to serve their communities and improve healthcare access, particularly in underserved and rural areas. So I will say all that to say, if anyone is interested in learning more about our programs, we could probably spend an hour just on them, but at the broad strokes overview, that is what you can expect AHECs to be implementing statewide. Next slide. So for the purposes of this presentation, we wanted to highlight a few areas where AHECs are making a significant contribution to healthcare education and workforce development across the state. AHECs, like I mentioned, are really committed to increasing diversity within the healthcare workforce with the aim of building a more inclusive and equitable overall healthcare workforce ecosystem. Our programs are dedicated to recruiting, training, and retaining health professionals. As I mentioned, those individuals who have a real desire to practice in underserved and rural areas, as well as being retained right here in Nevada. Fun story, I've been here for 16 years and I've seen campers become medical doctors. And it's a really humbling experience. It's not a quick fix, but it's a really innovative, long-term solution that really helps drive some really impactful opportunity throughout the state. In addition to that, we're really, as I said, emphasizing collaboration across various healthcare disciplines, preparing students to work effectively together. And this is really important because this approach enhances care quality and promotes a more integrated healthcare system. We're focusing on improving healthcare access in rural Nevada while providing targeted training for medical students and professionals to ensure high quality care within these communities. We're building strong relationships with community organizations, academic institutions, and industry leaders. Through these partnerships, we're helping to address local healthcare needs, as well as ensuring that our programs are relevant and improving not only statewide coordination among key and critical stakeholders, but as we learn from these key and critical stakeholders what the direct needs are, we have the ability to be adaptable and we can bring those needs directly into our programs to ensure that each of these students participating in each of these programs are afforded with the opportunity that is relevant and directly meeting employer and industry leader need. And then finally, with a rich history in Nevada, we have a super strong foundation for growth and we're very well positioned to expand upon these services. Our aim really is to build upon these successes and broaden our impact while advancing our work and increasing our overall reach. Next slide. So on this slide here, presented, you're going to see several testimonies from our students at various points of the programming. And then also, in the interest of time, we'd just like to invite you to reference this is our fiscal year 23-24 statewide impact report, just some of that data. We did include in the meeting package our statewide one-pager that will take a deeper dive into these outcomes. But, what's really impressive is that, I think these statistics really underscore the impact and their relevance on why we're here and having the opportunity to present, and why the commission has had the charge that they've had to really, address this issue. So just to cover a few of those notable numbers, we're very excited to share that a remarkable 91% of our K through 12 participants really express a genuine interest in pursuing higher education upon completing our programs. 67% of our program participants are representing underserved and underrepresented Title I and/or rural communities, which I believe really highlights our commitment to equity and inclusion. And then additionally, an encouraging 76% of our program participants enthusiastically agree that our programming has ignited their passion for a continued career in healthcare. And then next slide. And after that very high level overview, Gerald, I'm going to pass it back to you.
All righty. Well, thank you, Gerald Ackerman, again for the record. We just wanted to give you a few examples of some initiatives that are happening across the country within AHECS. And I'm just going to go over one of these because of time. This particular one is out of Virginia, and this is the one that I think, Joseph, you contacted us about and had some questions about. But the authority, which was established through the AHEC program, is committed to advancing Virginia's health workforce through a broad and integrated approach. It establishes a statewide infrastructure for assessing and planning workforce needs, engages health professions in training programs and decision makings, and serves as an advisory board for the Virginia Area Health Education Centers program. They collaborate with state, regional, and local entities. The authority supports policy development, promotes evidence-based strategies for workforce development, and addresses health needs in underserved areas. It aids communities in recruitment and retention efforts, evaluates graduate medical education programs, advocates for debt reduction for new professionals, and manages funding initiatives. Additionally, the authority fosters innovative workforce models, enhances diversity through demographic analysis, leverages technology for training, and develops a comprehensive careers roadmap to inform and engage stakeholders across the Commonwealth. I think in a small way, we're trying as our AHEC system to do a similar thing, but not with the resources that are there. So there are 3 additional ones that we included. Each of them are different. Each of them have been established to meet the workforce needs of those states. So they're from around the country. Many AHECs around the country, we could probably provide you with 40 of them, have similar initiatives that have been based on individual state needs. AHECs and the AHEC centers are uniquely positioned in that the aim of the program is to be the link between the academic medical health program and the community. The AHEC work on partnerships, collaboration, and the need of individual students, training programs, and communities. The following are those examples in those 4 states. We'd like to thank you for your time. I would note, I just had the opportunity when we talk about retention, which we didn't talk a lot about in today's work slide, is I just got to address 250 rural EMTs who are attending a Nevada Rural EMS conference, which is something that we've supported over the last 25 years plus to try to help in the retention of our rural EMS workforce. And they're all over there receiving 4 days worth of education. And that's done through many partnerships with the state EMS office, Great Basin College. So we work with everybody. I always tell people that my slogan for the AHEC program is I will come and dance with whoever comes to the dance. And so we look forward to the opportunity of supporting your work, supporting your efforts, and any partnerships that we can work with you on. So thank you for your time. I know we're close to our 20 minutes, but we'd be happy to field any questions if you have any. or follow up later through emails or anything like that.
Thank you very much. Appreciate it. That was very helpful. Any questions from any commissioners?
Go ahead,
Do you see
Marilyn.
any, Joseph?
Thank you. And thanks for that presentation. It's good to know that we're starting with them early. So I spent the summer with high school students across the state, and they really want like an app that they can go on because that's their generation. That's what they like. Andrea, I sent you an email. I'd be willing to sponsor something like that. That could be used statewide, because it's really what the kids want, but I want the kids to help create it. So I've been successful with 2 other apps that kids have created that actually work, right? So I sent you an email. I hope you'll follow up with me, but I'd be willing to sponsor that with some economic development dollars that I have that I think can be used statewide. I've asked colleges for information so I could get it together, and crickets every time. So if you respond to me and you could help me, I could do this and we could have it together by the spring for the kids to actually, so we're reaching out to them on what they want, not what we as adults want, but what the kids want.
Yes,
you
Andrea,
very
Greg, for the record,
much.
agree that we have to meet them where they are, right? We have that same conversation. Yeah, appreciate the sentiments.
Uh-huh.
Any other questions from commissioners?
Flocon, go ahead. Sorry.
Thank you. Thank you. I would just have a question about, you talked about funding. There was federal, state, some areas committed local funding from the counties, but you also received private funding. Can you just talk a little bit about that? Like how, I assume because these are not state-only programs, that they're independent. They look like they're public-private partnerships in many ways, but that you are allowed to get private funding from outside groups, correct? Corporations and others. And then how do you go about, I mean, are there events associated with those? I heard, I think you said there's fundraisers, only some of them do fundraisers, but some don't. So can you just talk a little bit more about that and how you would go about engaging one of these centers to receive or to give those kind of grant funding?
Sure. Gerald, do you want me to speak?
You
I
can do it
speak
or
for-
I can do it. That's fine. You can.
Happy to speak for High Sierra at AHEC, Andrea Gregg for the record. You know, what's noticeably different is that we're a 501c3 versus the 2 sister AHECs that are hosted. So as a 501c3, I absolutely think about that within longer term sustainability, right? So we have a fairly diverse funding portfolio and one that absolutely includes more of the grassroots fundraising effort, in addition to you know, seeking and aiming to procure both public and private foundational support. While we're doing that, Commissioner Flocon, we, you know, it's all mission aligned. And really what we're having to do due to our own restrictions is really hyper focus specifically on K through 12 so that we can keep those programs continuing to evolve.
And just some examples for you know, some of our university-based initiatives. We've received some funding from some foundational support for activities like our Health Career in Nevada's manual, which last year was funded completely by a donor. And we appreciate that, those efforts. As you were talking about that app, I was thinking how cool it would be to tie that to that Health Careers manual somehow, and maybe bring that to the next level. But yeah, you know, we always have funding restrictions and we always have, you know, mission restrictions, but I think both the university and Health Insight, you know, it fits the mission. And so as long as those funds hit, you know, hit the mission, we're usually able to go after those funds. Maybe not sometimes as nimbly as High Sierra AHEC is, but we're able to do that.
Thank you. Any other Questions from commissioners before we go to the next item? See any Joseph hands up that I don't?
Nope, not seeing any additional hands.
I thank you very much for that presentation. Appreciate it. So we
Yes,
go
thank you.
on to move to our next item on the agenda is item
Alright.
number 5. Sorry, go ahead.
No, thank you. Thanks, Chair Khan. Joseph Philippi for the record. Thank you, Andrea and Gerald, for your presentation this morning and your time. Next on our meeting agenda, we have an overview of the healthcare workforce website developed by the Division of Public and Behavioral Health. We have Dana Roscom, who is a Health Program Manager 2 with the Division of Public and Behavioral Health. And she's going to walk us through their website that they've developed and some future initiatives that they have related to the healthcare workforce space. So Dana, whenever you're ready, feel free to go ahead.
Awesome. And do you guys see my screen okay?
Yes.
I will do my best as Joseph's team to move around accordingly. So my name is Dana Camille Roscom, and I am the Health Program Manager 2 for the Public Health Infrastructure and Improvement section. I like to say one of the newer family members under the DBPH umbrella of programs. And I'm here today to speak to you about NV Health Force, our new healthcare workforce development website. Before continuing, I do want to extend my gratitude to the Commission and Joseph and your team for allowing me a space on today's agenda. So thank you. And before we dive in, we'll go over our mission, vision, and purpose as an agency, as they really are the principles as we think of our strategies and activities as they pertain to a variety of our program goals and objectives. So our mission is to protect, promote, and improve the physical and behavioral health and safety of all people in Nevada, equitably and regardless of circumstances, so they can live their safest, longest, healthiest, and happiest life. Our vision is a Nevada where preventable health and safety issues no longer impact the opportunity for all people to live life in the best possible health. And purpose is to make everyone's life healthier, happier, longer, and safer. And for today's agenda, I'd like to just formally introduce our section, again, the Public Health Infrastructure and Improvement section, also known as the PHII unit. We're pretty tiny, we're small but mighty. And then we'll take that deep dive into NV Health Force. Well, I'll share with you a little bit of our purpose, our insight, and just long-term vision for the site. I'll give you that website tour, as well as go over kind of the in the spotlight opportunity right now, which would be our ARPA Nevada Health Workforce Grant, aka our scholarships, and then discuss, as Joseph had mentioned, upcoming development plans as they pertain to NV Health Force. And then just as we gear up for our hard launch, we conducted a little bit of a soft launch, which I'll go over once we get to this agenda item. But pretty much what we intend to do as we gear up for that hard launch of early next year. And then I'll wrap up with some final thoughts and conclusions, and then open up the floor to you all for any questions. And then I heard a ping. Joseph, is there any questions? Am I good to go?
No, you're good. You're good.
Perfect. Thank you. And then hand the floor over to the commission for any questions. So diving in, public health infrastructure and improvement, again, the PHII section, we are led by Mitch DeValier, who's our agency manager. Our section priorities, I like to say we have lots of priorities, but this would be the top 4 currently, would be workforce development, infrastructure initiatives, quality improvement, and data modernization initiatives. Some of our larger programs and grants are comprised of the following list. So just an overhead overview of the following. The ARPA Nevada Health Workforce Pipeline Grant was essentially a request for application that we disseminated to the communities and our community partners, and identified both training providers and educational partners in disseminating educational and financial assistance opportunities to program participants statewide. And essentially that would allow students opportunities to select one of our components, our training programs, and receive certified training certificate or an actual degree, or at least use the assistance to help towards an educational degree, which I'll hit on later on in the presentation. We have the CDC Public Health Infrastructure Grant, also known as FIG. This grant is comprised of 3 major components, the first one being workforce development, the second one being foundational capabilities, and the third one being data modernization initiatives, which is then further broken down into 4 subcomponents. So data modernization, also known as DMI, is now further broken out into DMI Core, DMI Acceleration, DMI LDX, Laboratory Data Exchange, and recently we were just funded for modernizing immunization information, which is now another sub-hub for our DMI efforts. Moving on to our DBPH Public Service Internship Program. This is also under our purview. The Public Service Internship Program isn't new to DHHS or DBPH. We really are just working within our section to really formalize and just really unify the process internally and strengthening our partnerships with the universities and colleges. The idea is to just strengthen our ability to provide quality internships for students. And in return, hopefully through that time with us, we're building employable assets to fill our needs as an agency. And then moving into the Healthcare Workforce Working Group, this is led by our agency manager. The nursing apprenticeship program, I like to say we recently adopted in the last month. So I'm still kind of getting my hands into this program. What I will say notably is this currently is providing service to about 220 nurse apprentices statewide. And then also under our purview, we also play a heavy hand in FAB accreditation and those efforts. We're hoping to submit our application as an agency by the end of this year into early next year. And then lastly, Senate Bill 118. I'm not sure if this group is familiar with this, but essentially it's funding for counties across the state to help address public health priorities as they pertain to those counties. Moving into what is the thrill of the day, I like to say, it really is a passion project of mine, is Envy Health Force. And so really the purpose and intention behind the site stems from a variety of minds and folks who really came to the table and really just thinking from start to finish, what would it look like from a workforce development perspective to really just entice someone who's never seen healthcare before and at any point of your journey, whether it be your educational journey or career journey, really allow you to just look at the endless opportunities for growth and of course resources. So going to hit on these bullet points a little bit deeper. So again, just really exposing visitors to the vast opportunities within all health industries, public, primary, and behavioral health care. And with that, being able to act as a resource where we can link visitors to different opportunities, whether it be scholarships, career fairs, and programs, ensuring that they get that information on here. And then, of course, really highlighting and showcasing workforce development partners. As the previous presenters, they've shared just their awesome programs and their history with workforce development and making sure programs are highlighted so students can understand all of these different agencies, how they all collaborate and how they all interconnect. And then, of course, one big goal of ours was to essentially really head start that idea of a career trajectory and mapping out a plan for individuals to really think long term. And as you know, we're looking for, we always talk about instant gratification in the world of workforce development and how we really need to fill our needs and gaps as a state, but really also on the visitor side, just really helping them understand that there is the here right now, but understanding what that leap pad could look like from one opportunity to the next. And then, of course, working with our partners, one that I will name drop is Dr. Packham, who had asked if we could share just his information in terms of the data as it pertains to health provider shortage areas and just other workforce related data and have that be housed in our site as well. We thought that it'd be complementary to the information that we were providing visitors as it pertains to, you know, filling our needs and why these careers are so important and critical to our communities. And lastly, we really wanted to develop a site that was dually just as important to within our own employees in our agency, but also to the communities that we serve. So now that we have that, I want to make sure that there's no glitches. So I'm going to cheat, but I know Joseph said he'd sent out the slides. Everything in here is clickable. So I am just going to drag the website over just to ensure that we aren't going to experience any issues. Do you guys see that okay?
Yes, we're good.
Wonderful. Okay, so this is NV Health Force. And just to reiterate, we did conduct a soft launch earlier this year. And I do want to preface the group because I do know there was lots of excitement, but also feedback in terms of my industry isn't represented or the career I'm in isn't represented. We have that all in mind. I think for our soft launch, because of the ARPA Nevada Health Workforce Pipeline scholarships, we really wanted to have a home where these could be showcased and given the attention that it deserved. So just keep that in the back of your mind of as it stands in the right here, right now. So just the opening page, and we'll just scroll through and then I'll kind of take you through the different tabs. So we wanted to be very user friendly and just very much straight to the point. KPS3, who are website developers, really worked with our team and really discussed on like impactful snippets of information. And so that's kind of the mindset that we have coming into this, where folks visiting from any age range, any walk of life would just be able to obtain just the right amount of information to keep them enticed and hopefully wanting them to keep coming back for more education, information, and hopefully wanting to just peruse around the website in a more thorough manner. And so let's scroll up. One thing I want to keep everything organized as much as possible because we are currently in a second phase development. So let's start with the career pathways. So I will share what the future developments will look like, but let's just visit one of the career pages. So keeping that impactful snippet in mind, we are working on building out additional pages that represent all of the health industries. So again, public, primary, behavioral, and mental health. And so let's look at community health workers as an example. And so here we really cover that there are scholarships available. We cover the salary range, and there's just an additional link to what those averages look like in our state. The educational requirements to obtain this career, the different opportunities, and our partners and their point of contact if the visitor was interested in engaging with our partner. And then other providers who may not have the ARPA scholarship, but may have other opportunities or types of trainings in this field. And then other useful information. And then on this page, I do want to draw your attention to the career choices and growth. This is one thing that we will be changing up quite a bit in the next development. We understand, especially youth, their attention span is only so limited. And so we intend to just create more graphics and more visuals that really represent what a career trajectory from this starting point could look like and for all careers throughout the site moving forward. And then, of course, additional resources. So this is what you can anticipate every career page build out to look like. This is the format. Of course, we will, again, just be including more visuals. And I know a long-term goal of ours is just to also include testimony of folks actually working as these specific career types or professions. We think that will be absolutely engaging for our visitors as well. We then have a training and education section. I'll click on scholarships. And this just shows the current opportunities, scholarship opportunities that are available. Internships and apprenticeships. So if anyone knows of a great video production intern, you can shoot them our way. We still haven't filled this internship opportunity. And then we have the Nevada Nurse Apprenticeship Program. And so really navigating through this, again, it's really hitting on that resource and just current available opportunities. And with further development of the site, we'll change up the front page. So anything that's really time constrained, that those can really be the star of the page for that time being. And then with resources, as I mentioned in my opening, I'm going to try to pick a Good page. So let's do vocational and higher education. We've broken out our resources section based on learning and educational level. So here's the health careers, Nevada, or the healthcare careers in Nevada manual that the AHECs have allowed us to share on our site, and it's a direct PDF, a deeper dive into all the different healthcare careers. And then on each of the resource pages, depending on that educational level, we have essentially a directory of our partners and a descriptions of relative programs that cater to that specific educational level. And everything is a clickable link, so anything particular should direct the visitors to the correct pages. And again, just showcasing those partnerships and all of the key players in workforce development. And then also the medical workforce data that we had received approval by Dr. Packham to share is also listed on our site. And then lastly, one thing I wanted to end the tour on was the DBPH careers page. Just receiving feedback, word of mouth on our needs webpage to fill our own agency workforce development needs. We've built out just a solid direction guide on best ways to pull up healthcare related careers within DBPH, DHHS, and just really what those categories would be under. And then some of the current positions that we still need to fill. And so I really say in closing out my tour that this really is phase one. We are working tirelessly to get phase two underway. We're currently just waiting on BOE approval for our second phase two development contract to get things going on that. Okay, we're there. Perfect. And so again, just highlighting the current opportunity that's really the star of the show is the ARPA Nevada.
Dana, we're not seeing the
Oh.
slides anymore. Sorry.
Oh, you're not. Oh, sorry. I see it on
You're
my
good.
end.
You're doing great. You're doing great. It's a lot to navigate. This
I
virtual setting.
know. I have like 3 things up. Okay, wonderful.
There we go. We're good.
There we are. Okay, let me just make sure we didn't miss anything. Perfect. All right. And so again, just highlighting on the star of the show right now, the ARPA Nevada Health Workforce Scholarship. Here are the financial educational assistance opportunities. And again, these typically look like a sponsored certificate or assistance towards obtaining a specific degree. And so right now, the opportunities and the components are biostatistics and epidemiology, community health workers, doulas, alcohol and drug counselor interns, peer support specialist, master's level mental health programs, master of public health degree, lactation consultants, and other general scholarships to support public health training and education. So a variety of our partners and which component they are specifically programmed for will be listed in here. And I'm going to try and not mess this up by pulling up that page again. And so the PDF that is linked to that link will take you to a pretty much overview of our partners and just a deeper dive into their offerings as it pertains to the ARPA scholarship dollars. So that you should have access to, and if anyone's having trouble with any of the links in the PowerPoint, please just let me know. So upcoming developments, as I mentioned, we're currently in phase 2. We're just waiting on that contract be approved by BOE. But in the meantime, we have been working tirelessly in just the website reorg and content expansion of NV Health Force. So I don't know, it might be a little tiny on your screen because it's a little bit tiny on mine. But really, again, just breaking down health into 3 industries. So again, primary care, primary care, behavioral and mental health care, and of course, public healthcare careers, and then having a little arm just for our agency so we can showcase those career opportunities and career growth. So we feel that since the idea of NV Health Force really being that central site to provide that impactful snippet, the best way to also educate learners from across all ages is to have the site organized accordingly. So it's easy to navigate and it's easy to make sense from one career to another of how your career trajectory could look like. So phase 2, again, is primarily focused on a reorg, continually adding additional career pages. We're going to be refining our resources page just so it continues to make sense and that it's seamless across the site. Phase 3 is probably, I think everyone who's been working on the site, the thing that we've all been really waiting for and excited to really put a lot of energy into is the user self-assessment. So as I mentioned earlier in my presentation, as much as we do want to educate and inform students and learners across all walks of life on the different opportunities in healthcare, we want them to start, again, really think about just what their career trajectory looks like for them and being able to do so with NV Health Force. And so the idea is that we're still thinking about the specific metrics of what that would look like, but essentially based on someone's educational level, experience, as skill sets and passions, that hopefully we have a solid list of metrics where it would then become a self-assessment. And with that self-assessment, there'd shoot out 3 to 5 outputs of potential careers that would be in alignment for you right now. And then from there, as you navigate those pages, you would then kind of learn what the opportunities were in terms of that career trajectory. And so here's a really great visual of what Megan Kamlasi, our partner over at UNR, had developed, focusing on more careers within DBPH, but we're hoping to replicate this across the site and all of the career pages. And so as we gear up for our hard launch, January 2025, I know it's a real hard one, but I think we can do it based on again, this is just really a passion project for the entire section. We are, looking at just different ways to present ourselves as a government agency, especially at the younger ages. So our students, elementary school, middle school, and high school, I have some really great interns who are excited to really engage with the community in a different way. We're working closely with HR, and we're constantly trying to think, how can we utilize NV Health Force to just really fit with the times, is what we like to say. And so, and additionally, as we maintain the website, obviously we will continue to maintain our partnerships, establish new ones, ensure that the newest information is available. We're currently a little bit understaffed. We had a point person who would essentially take on that maintenance piece, but we're gearing up for a new person to be on board and can kind of take over those responsibilities. And then, of course, continue to collaborate with industry partners and just, further refine this site, and again, ensure that all information is updated. And then again, trying to reach out to the younger generation. We're currently devising just different strategies for social media and thinking of when we do conduct our hard launch, what that outreach looks like, what does social media marketing look like, and really just formalizing a communication plan essentially. So Joseph had asked to kind of wrap up my presentation with some final thoughts. So I know it's on the Commission's docket of things to think about sustainability for workforce development efforts. I think that's across the board. But when thinking about sustainability efforts, I think it is important to look at a holistic perspective from start to finish. As I mentioned, with a lot of grant funding that we see coming down the pike, it typically is asking for that instant gratification with the type of data they're requesting. And I think, with so much of the partners at the table having this be such a passion project for them, it's really looking at those early investments as well, like High Sierra AHEC and the other HAECs across the state, and providing that early exposure to students and really enticing them early on to really start considering and not be intimidated by anything in healthcare. Typically, the feedback that I receive from students, and we have 2 first-gen college students, and the more I'm trying to expose them to the different opportunities in public health, it's always that thought of like, that's a lot of school, or that's something that I never really considered. I don't have experience to do anything like that. So my hope, at least in my role, is to quiet down that background noise. And I know with NV Health Force, it's such a big website, but if we can at least play a little bit of a role to where we can assist students in just believing in themselves and just getting enough information to where it's not intimidating and we can connect them with the right partners, then that's a win-win for me. And then lastly, with the reconvening of the health workforce pipeline groups, I think this is important and this should really be at the top of the list. I think it's important to have all the workforce development key players at one table to not only discuss what their current initiatives are, but to also be able to ensure that we are addressing the current gaps and barriers as the community needs. As Joseph says all the time, we don't want to duplicate or replicate, but rather work collaboratively to fight the same fight. So I think reconvening of these groups is super important, and essentially would also just continue to market this idea of a pipeline to the community of what that actually means. There's so many players at the table that I think it can get a little bit confusing. And once a student completes a program, they're not really sure if this next program pertains to the experience they just received. So I think it's tying those relationships a lot better. And I think by having everyone in the room at one table, we slowly can do that. Oh, geez, sorry, Siri. And those are my final thoughts. Any questions?
Thank you very much for that presentation. Do we have any questions from any commissioners?
Mr. Walter Davis, go ahead.
Hi, thank you for the presentation this morning. And I was just wondering, we listened to the AHEC presentation, and I believe I saw on yours something for training for MAs. And I'm just wondering, is there a dual track similar to the AHEC presentation of other training programs that looks at the ancillary services or support teams as well too? As they go on the journey for looking at professional, providers, but also the support system that goes along with it. Is there any type of collaboration or anything we could think about doing in the future that helps with joining those two together?
So what you saw on the in the slide as it pertained to the medical assistance programs, that program's a little bit more unique. So that funding is to train FQHCs, well, not train FQHCs, but train MAs within FQHCs, specifically on how to best function within a federally qualified health center. And so that will support MAs who are currently working within that FQHC to be able to pretty much acclimate to that type of setting. But what we intend to do specifically with this site is, again, to be representative of all those ambulatory emergency services, and then work closely with our partners to see if there are any specific resources that would lead the visitor to either a scholarship opportunity or, as you've mentioned, what that looks like in a growth perspective.
Right. Thank you.
Thank you. Do we have anybody else?
I don't have a question. This is FloCon. I don't have a question. I just wanted to say how impressive that site was. I mean, the work that you guys have been doing is amazing, and I look forward to the next continuation of what you're doing. But I thought from a first step standpoint that it is really well done. In the organization of it and directing folks to the right place, and just having all the information, particularly on that first page where, it was kind of like, here's your opportunity, here's your pathway, here's what's available funding wise and scholarship wise and support. So just want to say very well done.
Thank you. Thank you. I very much appreciate that. I'll be sure to share that with our team.
And this is Joseph Filippi for the record. Just wanted to make a comment as well, if I can. The last couple presentations from AHEC and then the Division of Public and Behavioral Health, I just thought ultimately wanted to bring that information to the commission to show that there are, several healthcare workforce initiatives ongoing from various stakeholders throughout the state. These are just a couple of examples. And so, we're looking at, looking to provide recommendations on how to address the shortage of healthcare workforce. So I thought it'd be important to look at what the state is currently doing, what could be built upon. I mean, really, there's been discussion in the past, I think from Mr. Davis at a previous meeting where he said, there's so many things going on. We need one place where people can go to find all these different resources to see what all the different stakeholders are doing. So I thought Dana's website was a great example of an opportunity for that potentially. Of course, anything that like that requires funding. I think the division has been smart and used available federal ARPA dollars to do some of this work. And so as we think about additional meetings in the future and when we ultimately need to provide our formal recommendations, just wanting all of you to be thinking about and reviewing what we have been presented with and thinking of ways where maybe this is a great something that can be built upon, whether that means receiving additional sustainable funding or recommending these partners collaborate on an ongoing basis. I think Dana brought it up that there was those healthcare workforce development working groups in the past. That ultimately was an initiative funded through ARPA, which is now ended. But really, that was a prime example of where stakeholders working in the healthcare workforce space were meeting regularly, collaborating, talking about ways they can work together on addressing the needs of the state versus, maybe working in silos, competing for the same funding that's out there. So really just wanted to bring that up as a comment ultimately following these two presentations.
All right, thank you. If we do not have any more questions from the commissioners, we can move along to our next item on the agenda. It's item number 6. Joseph, you want to pick it up from there? Overview of the emergency department in home and a hospital at home care.
Yes, thank you, Dr. Khan. Joseph Filippi again for the record. So today we have Lisa Tripp and Shira Hollander from Tripp Hollander Advisors. They actually provided a presentation to our state Medicaid agency recently that I thought would be helpful for the commission to learn about as well. Part of the mission of our commission and our ask from the executive order recently is to look at not only the workforce needs of the state, but how to also increase access to primary care in the state and public health in the state. So I thought this would touch on that. I'll go ahead and hand it over to Shira to get the conversation started there.
Thank you, Joseph. This is Shira Hollander with Tripp Hollander Advisors. As Joseph mentioned, we're really thrilled to be here with all of you today. I'm going to let Lisa introduce herself and then kick us off on the presentation.
Yes, thank you. Thanks so much, Shira. And this is Lisa Tripp for the record. And thank you so much for inviting us, Joseph. It's quite an honor. And good morning, Chairman Khan and members of the commission. We are here today to talk about, as Joseph mentioned, a proposal that we gave to the Nevada Medicaid Agency. And also we are making similar proposals to various states around the United States, including Hawaii, Oregon, places with very substantial rural populations. So the reason that Shira and I are talking to you about hospital at home and emergency care at home and ultimately primary care at home is because Shira and I have been steeped in the hospital at home movement for the past 4 years. When Shira was at the American Hospital Association, she led the work that built on hospital at home in that organization. And I was at CMS when COVID struck, and I have a long career working for the federal government, but also with state agencies, state health departments and survey agencies on quality and safety in healthcare. And so because of my background, I was put on the team that wrote the waivers that allowed for care during an infectious disease pandemic to be provided differently than it normally would have been. And the last thing that I did was co-lead the team that wrote and implemented the hospital at home waiver, which is now active in about 39 states. And when I say hospital at home, I want to be really clear what I'm talking about. Some people hear those words and they think, well, they must be talking about home health. They must be talking about palliative care or hospice, things you normally think about being provided in the home. But that is not what we're talking about. We are talking about providing care in the home that is typically provided in a hospital, like emergency care, like inpatient level care. So that's to set the stage for what we're doing. And I left government about 3 years ago and joined Medically Home, where Shira and I worked. And we have been engaged in both advocacy and also in operational components of actually how do you provide this care at home. So the last thing, go ahead and go to the next slide, Joseph, if you don't mind. So an overview of this presentation is we're going to talk about the way Shira and I see this is from a paradigm perspective. So for the last 120 years, we've had a facility-centric paradigm to providing healthcare. So what do we mean by that? What we mean by that is we have built lots of buildings over the past 100+ years, and we have tried to bring as many people as we can to those buildings. That has been successful in a whole host of ways. But as we sit here in 2024 and for some time now, that paradigm, the facility building centric paradigm is failing to provide the level of access and quality that we needed to provide. And it's also creating workforce burnout issues that are very substantial. So what we see, and we'll talk about, is rural hospitals closing. Metropolitan hospitals are overcrowded in many, many places, including in Nevada, and workforce burnout. So what we're going to do is share our proposal. And because of my rich state and federal background, I think it's really important if you're going to try to innovate in how care is delivered, especially if you're talking about providing care in a home that would have previously only been provided in a hospital, you need to have all of the stakeholders present who can share in the learning, who can provide all the critical input about what is true in Nevada or what is true in Oregon in a whole host of different areas. We think that's really important to do, and so that's the paradigm that we are working in right now. What this would do is we want to pilot essentially how we can provide emergency care at home using principally community paramedics, mobile integrated health paramedics, who would be working with a virtual team of doctors and nurses, and that would be providing ED, hospital at home, and ultimately primary care at home instead of a building. This builds on your extraordinary work around community paramedicine. And it does a few things. And this is, I think, for this commission, the Patient Protection Commission, that is focusing so much on workforce. I want to make sure I highlight how this is a workforce agenda. Number one, it allows care to be provided in new places, right? So that's a big change. So instead of providing all this care in a building at the bedside, you would have it provided in the home or the community. That strengthens communities, and it strengthens the support in those communities. This care is provided by new teams. Okay, so we know we have paramedics who work in their lanes. We have doctors who work in their lanes. We have nurses who work in their lanes. This model of care pairs those resources together, and they become a virtually enabled but in-person care team, where you have doctors and nurses who are working with the paramedic who is hands-on with the patient. So that's a new team and new ways. And this is one of the things, and being involved in hospital at home for the years that we've been involved, what we hear, I'll tell you what we hear from our providers that's so powerful. One of the reasons Shira and I are just really, really have reoriented our careers to focus on this. You hear from paramedics, it's amazing to be able to provide care for people and not just drop them off, but actually be a part of their continuing care journey. We love hospital at home. You talk to nurses, and nurses say, I was so tired of the 12 hours a day on my feet. I couldn't do it anymore, but I love the opportunity to still provide nursing care when I'm using the virtual technology. And you hear from doctors that because you're able to see in patients' homes and you are in patients' homes, the power structure is different, and the learnings are different as well. You can understand the various and sundry reasons that are the root causes very frequently of why the patient is presenting. So that's the big picture. So let's go to the next slide. And because you all are so familiar with your, with healthcare challenges, I'll go through these fairly quickly, and I'll spend more time on the slides that deal with the type of proposal that we are working on. So this is our thesis for why the facility-centric paradigm is breaking down. Over on your left, you see a map that was produced in 2023, last year, by U.S. News and World Report. A startling percentage of rural hospitals are facing risk of closing. In this particular graph, it's probably hard to read, but the purple states are states where they estimate 40 or more percent of the rural hospitals are at risk for closing. You can see that Nevada is a purple state in this. So that's a very severe risk. When you have, we have the opposite problem in the middle spot here, where we have too many patients going to urban and suburban hospitals, and that creates all kinds of overcrowding. So you have things like hospital in the hallway, hospital in the broom closet, hospital, and this is not in any way a criticism of hospitals. They're doing what they can to meet the needs of the patients who show up. But it's obviously not ideal, and that's putting it mildly. There's studies that show it has deleterious effects on healthcare for patients, especially older patients. And then over here on your right, all of this has, if you're operating in a crisis environment, there's only so long you can do that. Has severe implications for worker retention, burnout, and so forth. So next slide, Joseph. So this is focusing now specifically on Nevada. And one of the things that's so impressive about Nevada is that you have been so forward thinking in innovating and using your resources differently, particularly in the paramedic space, which is what we are familiar with. But you are one of the fastest growing states in the union, as you well know, and you are heavily rural and frontier. So challenges absolutely remain. So next slide, please. And this is just a proof of the premise that hospital closures are happening. And so we have a couple of slides showing that. The thing that's interesting and very tragic about hospital closures is that it's not just that the hospital closes, it's that the ecosystem that the hospital supported also very often closes. So you'll see all kinds of physician practices that go away as well. So that it's a broader problem usually than just the hospital closing. So next slide, Joseph. And so this is from your Rural and Frontier Health Data Book. This is 2021. And this is the part I think that is really, is really just heart-wrenching, right? You can see the distribution of resources here in Nevada, and you can see that they're concentrated in your urban areas, and wide swaths have limited access. Obviously, that's a severe problem that is of great concern. And I will also add, just to pull back out for a second to the national landscape, every single senator in the United States, perhaps except the Rhode Island contingent, and has a rural health issue in their state. We think of states like New York, and everybody just thinks of New York City. The reality is New York is a massively rural state. So almost every bit of the Senate is worried about rural health. And so many House districts are also rural. And I bring that up to say that Shira and I believe that we can create new vehicles for care, new federal laws that could enable state initiatives as well, because this is a problem that transcends political party affiliation, and it's across the country. And this is the part that I think is so heart-wrenching, this quote from your Rural and Frontier Health Data Book. You'll see these very stories of patients that didn't survive because they were too far from any facility that could provide them the services they needed. And this is what we are one of the things we're trying to solve for. In rural areas, the economics will never, they're not set up to enable building new buildings. So our favorite phrase about this is we cannot build our way out of this problem. What we need to do is shift the paradigm and figure out how can we bring the care to them, utilizing technology, utilizing the liberalized payment structure, and learning together how much this would cost, what are the safety guardrails you need. So that's the thesis here. So next slide, please. Thank you, Joseph. And this is the last slide, sort of on the problem statement, if you will. This is a slide showing that a hospital, St. Rose Sienna in Henderson, at 110% capacity. You will see this across the country. Many states it's so normal for them to be over those hospitals, it's so normal for them to be at a crisis level of capacity that it's just become the norm. That is just not sustainable. And one patient mentioned he wasn't expecting there to be this much so crowded, and he made the comment, I was in the hallway. You can't sleep in the hallway with the lights on, people going by, bumping into the gurneys. And obviously this is not the fault of the hospital. They're just taking care of the people who come. So what we want to do is enable a care model where people who don't have to come to the hospital don't come to the hospital. I know that's been an area that Nevada has worked on and had success with as well. What we see is building on that to enable what emergency level care, inpatient level care, outpatient level care, and primary care. So next slide. So here's our proposal. It's really to pilot the combination of ED, hospital care, primary care at home with state stakeholders and in EMS agencies. It's very important. There are a variety of different efforts that try to do, and they call it hospital avoidance, and they typically try to go around the 911 system. What we think is important is let's support our 911 system. Let's find a way to add resources to that to prove the concept that this will benefit patients, the state's EMS system, and to share key learnings about safety, quality, and costs to inform regulatory payment and policy. So we think the benefits are giving patients a choice to avoid EDs, long transports to EDs, that if they don't want to go to the ED, they can get this care at home. And also to add emergency, outpatient, inpatient care options in rural areas, better allocate scarce healthcare resources. If we do not need paramedics spending hours driving to a hospital and then waiting to offload a patient, if that's a waste of resources if we can treat that patient at home and they want to be treated at home. Supporting the EMS system by reducing avoidable transports and decreasing overcrowding in the urban and suburban areas. So next slide. Thank you, Joseph. So what this slide is like, imagine that Nevada has said, yes, let's do this pilot. And we have spent a lot of time together. And by the way, when I talk about we, I mean, Shira and I have a team of the most experienced people who have designed hospital at home programs. They have designed and executed ED at home programs. They have designed and executed in rural areas these types of programs. So that's when I say the team. So we're day one of our pilot, and there's a 911 call, and the 911 call, we've already set up boundaries around what is acceptable and what is not acceptable to be a part of the pilot. So we have a call that's non-life threatening, and there's simultaneous dispatch of the ambulance team, which is at the top, and our pilot team, our community paramedics here. So next slide, please. And they both arrive at the patient's home. Now, we're theorizing a pilot that does not disturb the existing 911 response process, just for safety reasons. Could a state say, let's triage where you have a video visit, or you do something besides send to two different entities? Of course. but what we're starting from is the position we believe is the most safe. So we've got our ambulance out here at the house, and then we've got our mobile integrated health team at the house. And I think it's important that we think the paramedics, the official 911 responders, control the scene. They dictate what happens with, of course, discussions with the patient. So next slide, if you don't mind, Joseph. I put the slide in here, but just to, if there's any folks who are worried that this would result in people who need to go to a hospital, not going to a hospital, I just put this in to make it clear that we're very aware that there and would work with the state and all the stakeholders to define, here are clear rule outs, they must be transported. So that's very important to say. And the last point here where it says patient wants to go to hospital, we think that's really important. We think the patient choice is paramount in this concept. If a patient wants to go to the hospital, even if they could be treated at home, they go to the hospital. So next slide. Okay. Now, imagine we've got a patient and they are an hour away from the nearest hospital. They have an exacerbation of their congestive heart failure, and our team they talk to the paramedics, and our team and the patient agree, hey, this patient can be treated at home as part of the pilot. So you will see the doctor is up at the top of the screen. We have a video visit that has been initiated. So, and then down below, we have a mobile integrated health paramedic that is part of the physician paramedic team and the patient. The patient will be consented. They will be provided informed information about the risks and benefits, and they will be free to consent or not consent. And now we have another evaluation. So we've had an evaluation by the paramedic team. And by the way, that paramedic team is now, they don't have to spend the time, which in some cases could be hours, transporting a patient. And during that transport, the patient's not getting care. So now the patient is actually getting care faster than they would have gotten. And we're not consuming those resources by moving the patient around. And so there's going to be an evaluation. We'll have point of care labs with that paramedic. There will be point of care ultrasounds, all kinds of diagnostic tests that can be done now thanks to technology. And so next slide, and this is the last slide. And I apologize for speaking so quickly. There's just a lot to get through in a short period of time. So thank you for your patience in that. So now we have, you notice we've got an IV here for this patient. We've got the patient is on their own sofa. We're doing a pulse ox with the patient. So that mobile integrated health paramedic is going to come with a whole bunch of healthcare supplies to be prepared for the needs of the patient. Got the family member there, of course. So what can happen? And we would have so what would happen? Patient can needs inpatient level care, they can get it. And if that's the case, then this paramedic is going to leave a technology kit that includes like an iPad. And if this is an area where you can't get video, then audio should be okay if it's appropriate for the patient. And that would be a decision made by the state and the stakeholders and the team that's working on this pilot. You would have a router with internet. We can do that. We can bring the internet to people now if they have cellular service. We've been doing this for years, and it's been very, very effective. So you don't have to have internet. You don't have to have broadband. You just need to have cellular service. Of course, if you're so far out that you don't have cellular service, then that creates a different type of issue. But so we have backup batteries. We now have backup batteries that are small. They can easily have backup power for 12, 14 hours. In the next few years, they'll be even smaller and they'll have longer backup power. And all of that's installed by the paramedic, and that paramedic orients the family and the patient to how to use everything. It's a very important part of this. And so that would be like an inpatient stay. Or the patient may not need that level of care, but we're not sure if they're appropriate for what would be observation level care, then they can do that as well if it's appropriate. And there are bills right now pending in the Senate and the House to pilot observation at home. The patient can be treated and released. Okay, so the patient would get the video visit physician can give a prescription that would need to be filled, but also the paramedic on site can give that initial dose. And perhaps there might be some way to create a dispensing mechanism. It just depends on what state law will allow. And there could be connections made to other, home health, palliative care, also the social services that the patient may need. We're gonna have a much better insight into all of the different things this patient needs when we're in the home talking to them. And I see number 3 is what I see as like primary care. This is a version of primary care. It's just done by that initial physician. And then lastly, transport to another care location. If you need a test that you can't get either at home, but you don't have to go all the way to the hospital, you can get it some other place. Or if the patient either has decompensated or the patient, the physician is like, I think this patient needs to go to a brick and mortar. This care team can take them to the brick and mortar. So this is the idea of taking pieces of our healthcare system, using them in ways we have not before to really strengthen our communities, give different options for different players to work together. And this is not we're not trying to close hospitals. We're trying to add services that ultimately could be provided by hospitals or whatever the structure the state would deem is appropriate. So that's the end of my presentation, and I'm excited for any questions that anyone may have.
Thank you so much for that presentation. And yes, it was a lot to cover, but you did a tremendous job. We have a couple commissioners with their hands raised. So Marilyn Kirkpatrick, please go ahead.
Thank you. So to be honest, this would make me super nervous, and then allowing the legislature to design a program even scares me more, right? Because there are a lot of health experts there. But I mean, how does this work? And offline, I'm happy to ask. But I mean, there's franchise agreements in place, and Washoe and Clark and. Two, we already have a shortage of paramedics across the state, let alone the nation. And what I wouldn't want, and ironically, someone has came to me on this, but they want it for the rich neighborhoods. And I said, get out of my office, quite frankly, because everybody should get paramedic care. So, I mean, I just am wondering, what states have you done it in? Because I serve on a national board or two. But I'd be curious because this is putting a lot in somebody's hands. There's liabilities, there's oversight, there's all kinds of things. So
Sure. No, I appreciate the comment. And when I first heard about hospital at home, Maryland, my initial reaction was, this is crazy. I have no idea what kind of scam people are trying to pull off, and it makes me very nervous as well. What I learned subsequently after talking to the experts who were at who in the states, Johns Hopkins, Mass General, Brigham and Women's, Mount Sinai, that had been doing versions of this, is that there's a very long history of hospital care at home that's been happening in places like Australia, the United Kingdom. It started in France in the 1960s, actually, Israel, Asia, and so Spain. Many countries have been doing hospital at home for a long time. We did a bibliography of about 350 studies, and when you look at all of that, what you see is actually the benefits of being home are very substantial, and the outcomes are really good. Lower readmissions. Most studies show lower mortality. The infection rate, by the way, is nearly zero. So if you're not going to a hospital, which is essentially a box of infections, you can take your infection risk from that encounter down to almost zero. So I certainly appreciate the question and the comments. And just to also clarify, I was not intending to imply, and I apologize if I did, the idea that that at this step it would be partnering with the legislature. I think the only way something like this could work would be to partner with healthcare experts in the state. Jake Keeperman is an emergency physician, and Jake is a Reno resident and has been an ER doctor in Nevada for many, many years. And he is an expert in this model of care and has been working in it. It's ED at home has happened in a host of different states in the country. And I'm happy to discuss more offline. But if to the extent you're saying this is worrisome and it scares you and it may not be safe, please rest assured that I certainly had the same concerns when I first heard about it as well.
So this is Dr. Khan. Is there somebody else wanting to speak?
Yes, we have several questions or hands raised, Dr. Khan, but Marilyn, did you have any
Go ahead
follow-up
with those
to that
people.
or follow-up questions?
No, I'll just reach out offline. I don't want to tie everybody up. So
Okay.
I have a lot of questions, quite frankly, but
Okay.
I'll do it
Sure.
offline.
And Mr. Davis, go ahead.
Yeah, hi, thank you. This is definitely thinking outside the box. And, actually it's kind of exciting in some ways. My question is on the payment system and reimbursement. Obviously, this certainly has to hopefully help reduce cost of hospitalization and dealing with the insurance companies. And so has any information been you can share on the billing process and how that would work in this
Sure.
model?
Yes. So the way that Medicare, so the waiver that we put together when I was at CMS, the operating entity was a hospital. And so the hospital got paid the way hospitals get paid, which is by rural hospitals get paid one way, but just generally the DRG payment, right? So we kept the DRG payment the same because we did not have enough data to know what the actual costs were to provide this care. And we did not want to disincentivize it, especially in the middle of a pandemic. So right now, most payers are paying for hospital at home the same way they pay for brick and mortar hospitalizations. But let me add that here's one thing I think is really important. We need most of these programs, some of them are in rural areas and they've had very good results, but most of them are not. And so what I know to be true is it costs more money. If you're going to bring care to people in rural areas, that costs more money than bringing care in a metropolitan area. And that's why, Mr. Davis, that's why piloting is so critical. We want to understand what the real costs are to provide this care. And you can imagine if in mine and Shira's, 5-year plan or 10-year plan or whatever it is, we see Congress authorizing payment for this. And we've had conversations about this with key staffers, and they're hungry to do something about access to care for rural people. So where I'm going with this is we want to pilot it in 4 or 5 states at a minimum and say, hey, Congress, here's what you need to do. You can take a DRG payment and maybe adjust it down in a metropolitan area, but because the costs are less. But in a rural area, we want you to take that DRG payment and ratchet it up. Or if it's cost plus, it'll be something. But you may have to pay more to reach rural patients, but you'll offset that cost by likely a decreased payment in a metropolitan area, such that the math will ultimately work and you can still add resources in ways you can't add them right now.
Thank you. And just one last question on there. I'm very interested in learning a little bit more from a federally qualified healthcare center standpoint, because we have established discharge healthcare centers. And I saw something in your presentation that talks about transporting them to an FQHC. And so I like to, offline probably talk a little bit more about some other additional thoughts in addition to our homeless program too, where we have the
Yes.
paramedics coming as well. So there's a few
Yeah.
things that I'd like to just talk to you about
And
afterwards.
we have a combination of two things that are really important. We have a
Mhm.
great desire to learn more from you and from everybody as part of this commission and this audience.
Mhm.
And we don't have any baked ideas necessarily. So we think it's important for the states we're talking to like, all right, what is your resource? What are your resources? What does it look like here? And how can we make it fit here? Because the last thing we want to do is destabilize anything. We want to support what's there. And so I appreciate that comment.
Is somebody else before I go with the question?
Yes, Bethany Sexton, please go ahead.
Hi, thank you so much for the great presentation. Kind of along the lines, I think, of what Walter was asking around some of the payment options. Also, how do you think about the maybe I think you're calling it kind of a sponsoring entity or the hospital? Are you really working with some of the near site hospitals, meaning those hospitals that are in rural environments, or are you really thinking about that being a hospital that is potentially in a more metropolitan area and maybe larger?
I think it's a great question. I think it all depends on who's interested and who's willing, who wants to embark on something like this. But for sure, Ms. Sexton, I think that we in talking to this with folks who are very much entrenched in the critical access hospital community, in the rural hospital community, some people say immediately they love this idea for those hospitals because it could add a way to provide care that they don't have right now. So that could create opportunities for greater services and greater revenue to keep those hospitals stable. So my sort of philosophical orientation is absolutely that would be amazing. At the same time, I know enough to know nobody wants to be like, hey, I've got this great idea for you, and they're not interested. So I think it just really depends on who's interested in trying to innovate like this.
Thank you. We have a couple more hands raised. Flocon.
Yes, thank you. It's very intrigued. I'm very intrigued by the idea, but I agree with some of the other commissioners from Maryland to Walter to others just about some of the trade-offs that could occur. So a couple things that I'm thinking about, and I'd love to get, how do you measure quality of care? How do you ensure in a hospital setting, you're going to see it, there's certain requirements, obviously, that hospitals have to report on to ensure that quality of care. And this seems like just sending someone out and having them do something. How are you going to measure whether or not they're actually getting what they need and how your patient outcome, right? That's one. I do think going on that too, not only are we looking at reimbursement, but what is covered by insurance? Like, I mean, obviously there's core things that you go into a hospital, there's, they've got it coded, all of that. How does that relate out into the field in terms of that coverage? What does that look like? And how, when you talk about out-of-pocket costs for the consumer, does that change than it would any hospital setting? So those would be two of the things. And then my final would be, as you said, this is really new, right? I think it's on a test basis, hasn't really, like what kind of changes are needed in law to allow for this to happen? And we're talking about not just in a state program, but commercial space. So a lot of things thrown at you, I know, but thought I'd throw them all out there.
If I don't remember all the questions,
okay.
Please prompt me.
Quality of care first.
Thank you. Thank you so much. Quality of care first. So, It's a really a very important question. If you're part of the CMS hospital at home program, you have to report pretty much all the same quality measures. But let me tell you that the reason you talk to people who work in this model of care, they love it. And that's because the patients love it and the providers love it. And so we are at the CMS program, we always required reporting, on top of all of the other measures that you had to report for inpatients, escalations back to the brick and mortar, unanticipated mortality, and CMS evaluated unanticipated mortality last year, and they concluded that the unanticipated mortality in hospital at home was lower than what was happening in brick and mortars. So that's one thing. The other thing is this has been happening for decades across the globe. So to the extent we are open to looking at international data, there's a rich body of international data, including meta-analysis that shows, generally speaking, lower readmissions. They show lower discharges to SNFs, and that's a huge one. They show, and here's the patient-centric satisfaction metrics: more sleep. Nobody sleeps in a brick and mortar hospital. I mean, unless y'all have them differently than anyone I've ever seen. People sleep more, they move more. And for our elderly population, that is so important because it's not uncommon for an elderly person. And I spent most of my career focused on nursing home residents. So I have a lot of experience with this. You'll have that elderly person will have a degree of mobility. They stay in the hospital bed where they basically never move except to go to the bathroom, if they're even doing that, because they could just be on a bedpan. They come out, they've lost range of motion, they've lost dexterity. So now they need a sniff stay where they didn't before. So people move more, they sleep more, and frankly, they have less depression and less delirium. And that's really critical. Again, with the elderly population in mind, the studies, many studies show much less delirium, which is, we all know how important that is. But patient satisfaction is very high because of the value of staying at home. You're not in an institution. I mean, that, like, hospitals are institutions. And like I said before, if anybody is hearing this and saying, I'm worried about it, is it safe? I had the same worries myself. I very much so had the same worries. So I understand those concerns. You asked about cost, and I think cost sharing. The way it's set up under CMS, there's no difference to whether you're in a brick and mortar or not, right? And also, if you contextualize this in a hospital context, ED care is paid for, inpatient care is paid for, outpatient care is paid for. So one way to do this is they just pay the same thing. What we want to do, though, and value-based care, right? This is a great opportunity for value-based care so that you could provide a longer continuum of services for the patient and have that team. And this is also really important to me. I've spent a lot of time in my career talking about transitions of care. Transitions of care are bad. We spend a lot of time talking about how to make transitions better. I love this care model, especially if we could do it in a bundled payment sort of way. So it's a longer runway of care. The best way to deal with the problems of transitions of care is to stop having so many transitions of care. And so to the extent we could do acute and post-acute as a bundle together, then you have a continuous care team, which not only helps patients, but it adds satisfaction to providers because they're not working like a factory assembly line. And that's what a hospital is. That's a big paradigm shift. Part of the reason I'm so passionate about it. Last thing I'll say about cost. We need to understand what the costs are of this for rural patients before you can even talk about payment. And I feel like that's really important. And that's why piloting this with the smartest caregivers and the stakeholders in a state is, in my view, necessary to even start thinking through this.
Thank you.
And anybody else before I ask my questions?
We have Jalen Behunin and Wendy Simmons.
Hi, thank you so much for this presentation. It's not the first presentation I've heard about hospital at home, so I know that it's being done around the country. But my question and concern is about the healthcare workforce. So, you know, with it in a time where we've got a shortage anyway, we're having a hard time in hospitals and post-acutes staffing. If you pull that workforce to the healthcare, to the hospital at home, with it, you know, and it looks like they have more time or one-on-one time with the patient.
Yeah.
What is the impact on the workforce where we don't really have a strong pipeline yet to backfill all of those positions? Have you seen any data on that?
It's a great question. I don't have data at the top of mind, Miss Behunin, but I will tell you, like the health systems we worked with, they were staffing their hospital home programs with nurses who were about to leave the profession because they couldn't do it anymore. Physically, it was exhausting. So we know it's a workforce retention for nurses who are getting older, and not just older, but also ones who have physical disabilities, or you have family that you need to care for, that going to work, that hour it takes to get there and the hour it takes to get back. If you can be virtual, you can solve for those things. The other thing is with paramedics. Now, let me also be clear. I don't mean to sound cavalier about this. This requires planning and thought, and what I believe it will do. If we had this conversation, if we could get in a time machine and it's 2035, what's going to happen, will have happened, I hope by then, is nursing schools will be teaching this. Paramedic schools will be teaching this. Physician training will be teaching this. It will become a normal, accepted option. And the way that option could work is, and it does work in a variety of hospitals right now across the country, is the hospitals you'll do a month virtual, and then you'll do a month bedside. So you don't have to do one or the other. It gives you an ability to flex. And that's valuable to everybody, I think, and particularly to our younger folks who are much more tech, sort of expectant, for lack of a better phrase. But I hear you, and that's why you have to be careful in how to do this so you don't destabilize already overtaxed health infrastructure. So I completely understand and totally agree with that concern.
Thank you. We have Wendy Simmons next.
Yeah, thank you so much, Joe and Chairman. Lisa, very interesting presentation. I've been in healthcare a long time. I personally have experienced benefits of a house call model from geriatric specialty groups that managed care and services to individuals in long-term care settings, residential care. And there is a great benefit. I support what you said as far as people decompensating, clinical delirium when we transport, and certainly out of rural areas, an hour ambulance ride gives a different presentation when you hit the brick and mortar. So thank you. Thank you for your innovation. I can't believe anybody that worked with CMS is actually coming out and having innovative ideas. So thank you for that. I think I would be curious, and I don't think you have an answer for this, but I'll just put it out there. Regulatory oversight, because hospitals are regulated and surveyed and monitored heavily. It will probably be a step that would require some extra effort as you work through how regulations are defined for the model. And then the second question that I would pose is the immediate on-site and the testing that could be done that would make a determinant as to whether we're going to transport to the actual hospital setting or continue to treat at home. While patients do better at home, a concern would be after the mobilized team leaves,
Right.
what is the rollback if something gets a little bit sour in the first 12 hours.
Yeah, no, that's a great call out. And that's something that the clinicians that we've worked with for years, have spent thousands of hours thinking through that decompensating patient question. And I think that's a very valid, important concern. I will also add that and they have solved it to their satisfaction. Just that's an area that is worked. Also, technology at this point, like think about what we can know about a patient immediately is very different than what it used to be. And last thing, Ms. Simmons, I'll say is your focus on regulatory oversight and survey agencies. You're singing my language, because my first major job out of law school was as a lawyer for CMS, who litigated cases against nursing homes primarily and some hospitals that violated conditions of participation for health and safety. So I did that for 6 years. I was a courtroom lawyer, um, litigating those cases. So I know those rules and regs very well. I can also tell you I've stayed close to that community. And I have been speaking at their annual conference, the State Survey Agency Directors Annual Conference, for many years. And I spoke at it a few weeks ago. And I'm still very close with a lot of state survey agency directors. And here's what they've said: no complaints. They have hospital home programs in their states for 3 years. They've not received a single complaint from a patient yet. And that has taken some of my dear friends from big skeptics, like, not in my state. That's a literal quote. Not in my state are we doing this, to the biggest advocates. It's part of it is they talk to the patients, they talk to the families, people really respond beautifully. So, but that's part of the whole piloting. Come up with the right regs and not just apply existing hospital regs that are built for a model of care that's facility centric. Let's come up with the right regs. That would be, in some cases, more expansive in some areas, less in others. Obviously, life safety code, we're not going to be running through to make sure you get sprinklers in your house. But I appreciate your comments, and the nursing home population is part of the reason I'm doing this work, because the best thing you can do for a nursing home resident is to never make them one, if at all possible. This supports people in their homes, and that's why we're passionate about it. So thank you.
Chair Khan, please go ahead.
Thank you. Thank you very much. Very interesting discussion and diverse thoughts and perspectives. I have several concerns in this model. First and foremost is a huge liability issue. There's a paramedic who's making a determination what's happening, etc., and has access to a physician via telemedicine or what have you. And based on those two discussions, they decide this patient can go to home hospital or to the regular hospital. Mm-hmm. There itself is a problem. Now the clinical decision is handed over to a paramedic with a phone call discussion with a physician sitting long distance, in most cases out of state. That itself is a concern, because in Nevada, to be able to give opinions and practice medicine, clinical medicine, you have to be licensed in Nevada. So, but that's a separate issue. Having said that, that's number one. Number two, there's a conversation about observation status, which under CMS guidelines is allowed a 2 midnight or less than 2 midnight stay in a hospital environment for diagnostic workup, specifically to come to a conclusion whether this patient's condition is such that, based on the diagnostic testing, which is extensive, the patient is cleared, everything is fine, all this is negative, etc., go follow up with your physician. So they are in the hospital, supposed to be less than 2 midnight. However, should they have a positive finding based on some of these diagnostic tests, and they require further services, then they are rolled over to an inpatient, which rolls over then to a DRG payment system versus an observation system. Here we are taking the patient to a home. Whatever the home condition is there family, is there an adult, are there elderly people at home, who's around, etc., etc., etc. That's a full social service department in a hospital that assesses that home situation. And based on the home situation, the social service and the case manager in a hospital determine that this patient is safe to go home or not. Here we are taking a patient from the ambulance after a conversation with a physician on telemedicine into a home, assuming the home is fine, and setting up whatever it is. No diagnostic testing available to determine what's really going on with this patient, whether it's a CAT scan, whether it's an echocardiogram, whether it is an ultrasound, et cetera, that needs to be done to determine is the disease or a condition significant enough for a patient to be in a hospital or just the outpatient. Situations like this happen sometimes if a patient is discharged prematurely from a hospital, which is not very often, but that does happen. And the patient gets to a home environment after all the checks and balances, and they crash and come right back. Here, the hospital charges an observation code. They have 24/7 monitoring of this patient with this by the staff, available at the beck and call of this patient by a nurse or whoever. In the slightest change, a doctor comes in without the gap of now calling an ambulance. Oh, by the way, I think now this patient is having a heart attack. Let's call an ambulance after we've spent 24 hours or 48 hours in a home. And now we're in a hospital. If within those 48 hours or so patient is getting worse, he's right or she's right there without compromising the critical time required in certain heart attacks and strokes. It's a minimal time, 1 hour, half an hour time for this patient to be taken care of immediately for intravenous dissolvents, etc., etc. So I have some very, very serious concerns about the safety of the patient in the environment of a home. Home hospice is something people accept for the reasons that were mentioned. Well, you're in your home environment, you're more comfortable, etc. And even the home hospice doesn't stay with you 24/7. But the idea is totally different. Patient's terminal, there's family member that they can take care, and as need be, they can call hospice if they have concerns. Somebody comes in to give intravenous medications, pain medication, etc. For anything that is considered acute care, personally, I think I have serious concerns about the well-being of the patient. Just because we don't have services in the rural environment doesn't mean that they need second-grade services. Doesn't mean they receive more high-risk services. We would not do this in the middle of the city where a patient who has access to a hospital straight away and can get there. So I don't think the rural people deserve. There are a lot of other things to be considered. Yes, it's a challenge in the rural areas. Yes, it's hard to get doctors and staff in a rural area, and therefore the services are deficient, etc., etc. But I can go on, but in the interest of time, I have many serious concerns in this whole concept. There may be a time, you mentioned many countries. They are all countries with socialized medicine. Their systems are so clogged up that the patients have waiting times of 30 months and 18 months and 20 months. Even somebody who has had a heart attack, even if they went to the ER or discharged, wait in line for your surgery. Australia and all the other countries, that is the system they have. So they are compromising to get to something like this, that something is better than nothing. So let's do this. So that is why it is happening. I'm very familiar with that system also. I've lived there for a couple of years, a year rather, many years ago. So those countries are not the best examples because they are cutting corners to provide services because of funding and pressure on the system of volume of patients. I'll stop there and go from there.
I will want to respond to a few things, couple things. The sort of characterization that this is second-class care, I think, would be strongly refuted by the many physicians and nurses and paramedics who practice in this model at institutions like Mount Sinai, at Vanderbilt, at University of Chicago, at Cedars-Sinai, at the Mayo Clinic, at the Cleveland Clinic, at community systems throughout the United States. They are, I think that their patients would also strongly push back on the notion that this is second-class care. So just wanted to make sure I said that. In terms of the observation point, very obviously to me, and I should have been clear about this, there's a lane where this would clearly not work as an observation status situation for sure. But there is a lane where it could. So like I said, I certainly appreciate anybody who's concerned about safety and quality. I shared those concerns and continue to worry about safety and quality in general. But I appreciate the opportunity to be given a fair hearing on that, and I appreciate your responses to this concept.
So let me give a little follow-up on the various institutions that you just mentioned. The concept that is being used, and also in some places in Texas that I am also aware of, they use these things for long-term services, patients with a tracheostomy on a ventilator that are not going to come off of it forever and ever. And in those cases, programs exist under the sponsorship of those hospitals where they are monitored at home for their chronic conditions, that instead of occupying a hospital bed for weeks and months or a long-term acute care bed for long-term, when there's nothing acute, they have a chronic condition that'll linger on for a long time. In those cases, the home hospital concept originally started, that take away the pressure from the hospital bed, they can be home, and there'll be a payment for a nurse to be with them to suction their throats, et cetera, monitor the ventilator, and what have you, or other chronic needs. Those are the places where most of these institutions, to get the load off the hospital acute care beds, came up with this idea of a home hospital where they will provide the services for this chronically ill patient. That is what has happened in most of these places, and I'm aware of them firsthand also.
Just I would add that CMS is going to be submitting a report to Congress that will be an exhaustive. I would invite anybody who would like to look at how this program has functioned since November, since the beginning of the pandemic, to take a look at those reports. They'll have a description of what length of stay is, what the typical diagnoses are, and so on and so forth. So that will be forthcoming by the end of this month. And Joseph, we're happy to, once it's published, we're happy to circulate it to you, and you can share it out with the members of the commission if you like.
Lisa, this is Joseph for the record. I think that'd be very helpful and would provide the commissioners with some additional data points to consider. But really appreciate the overview of this model. We have another commissioner with a question. Bethany, please go ahead.
I think you're on mute.
Yeah, sorry. Thank you. Chair Khan just would push back a little bit in saying that I think these types of models are worth us continuing to evaluate and look at the data and actually bringing that forward. I mean, for a very long time, we didn't think that orthopedic surgery, like a knee replacement, could be done as an outpatient surgery. We didn't think that a cardiac cath lab procedure could be done as an outpatient same-day surgery. So I think it behooves us to continue to push the envelope, and technology has come a long way in terms of being able to support many services being provided remote, virtually, digitally enabled. And so really appreciate the topic being brought forward, and would continue to like to be able to look at some of the data that's coming out from those areas that do have these programs in place and understand better the kinds of services that can be rendered.
And I agree with you 100%, Commissioner Bethany. It may evolve eventually, like you have mentioned about other areas of medicine. But until it evolves to a safe delivery process, studied thoroughly, investigated, the outcomes, et cetera, all of that stuff. For example, the outpatient surgeries, the cath labs evolved over decades. And so things evolve over a period of time after extensive data is available, thousands of cases, for example, in cath labs, use that example. What was the outcome? What was the risk factor? How many patients crashed on the table in an outpatient setting and had to be rushed to a hospital? All that data took a while. And this may come to fruition at some point down the road. But a lot of studies, data has to be collected, information has to be collected from diverse geographical locations of the country. And then perhaps at some point, it may be considered, yes, safe, things are okay statistically and quality of care wise. And then the time will come.
Excited to see the data when it comes out.
Yep.
Sounds like soon.
Yeah, we'll send we track the various peer-reviewed studies that cover hospital at home, and we'll share out we can share the whole bibliography, but also some of the recent studies that were in the US in different geographies. So we're very happy to share the data, and obviously the data matters a great deal.
Sure, thank you for that. Anybody else with a question?
I'm not seeing any additional hands raised.
All right, thank you very much.
Thank you.
Joseph, you have a next item on the agenda. 7 is public comment. Do we have any public comments?
Thank you, Chair Khan. Joseph Philippi for the record. For anyone attending who wishes to provide public comment today, please raise your hand through the Teams platform, or press *5 to raise your hand if joining by phone. Chair Khan, I'm not seeing any requests for public comment today.
Did we get anything in writing ahead of the meeting? I think you shared something with us from, I believe, the Hospital Association. Did you get anything after that?
It was actually from the Nevada Academy of Physician Assistants. That'll also be posted publicly to the website. I believe I did email it this morning to all commission members. Happy to read that if it would be helpful.
I think it should be all right. If you have sent it to all of us, we can read it. And if there are thoughts or comments, we can discuss them at the next meeting.
Perfect, thank you. But no other information has been received virtually that I'm seeing. But if received, we'll be sure to forward it to commissioners and post it publicly as well.
Okay, thank you. So the next is the adjournment. Do I have a motion to adjourn?
Sorry, Dr. Khan, before we move forward with that, I just wanted to quickly make an announcement for the commission. So prior to adjourning the meeting today, just wanted to acknowledge the work of the PPC policy analyst, Madison Lopi. She's been with the commission since June of this year, has really been really helpful to me personally in supporting the commission and doing a lot of behind the scenes data and policy research that really helped a lot when we were all formulating the BDR concepts that were submitted. So today's Ms. Lopi's last meeting with the commission. Just wanted to thank her for her work. She's actually received a promotional opportunity within the department, so she'll still be with us, just in a different capacity. Just wanted to publicly acknowledge Madison for all of her work.
Yeah, thank you very much, Madison.
Thanks, Joseph. I also want to take this opportunity to thank you all. It's been a wonderful experience, especially through the BDR process. You all are doing great work, and I've learned a lot even in this short time. So thank you so much.
Thank you. Anything else, Joseph?
No, sir, we can move forward with your motion.
Okay, so we have a motion to adjourn.
I'll move. This
Second.
I'll second.
Okay, and nobody opposed, I presume? All right. Thank you very much, all of you, for your time until we meet for the next meeting.
Yes, thank you all.
Thanks,
Thank you.
everyone.
Thank you.
Have a great rest of your day. Thank you to our presenters for your time as well.